Hello, today I'll be talking about developmental venous anomalies, and these are lesions which are actually much more interesting than they appear. So I hope you enjoy this one. So, diagnostic criteria for developmental venous anomalies, essentially what we have are multiple deep parenchymal veins which converge into a larger collector. And these veins follow a transhemispheric course before they drain into a normal deep or superficial vein. And it's important to point out that these veins drain normal cerebral tissue. So if you were to injure or occlude a developmental venous anomaly, you would essentially get a venous infarct in the territory of the normal tissue that it's draining. DVAs are associated with absence of a venous pathway which would normally drain that territory. So essentially, if you have absence of a superficial cortical vein that would normally drain, a gyrus, you would get a DVA going through that gyrus, through the white matter, and then into the deep venous system. So the pathogenesis of these lesions is somewhat unclear. It's thought to be due to a microthrombosis or abnormal development of deep or superficial veins early in embryonic development, although we have absolutely no real evidence as to whether or not this is the case. It's also thought to be a functional adaptation to venous occlusive disease with recruitment of transmedullary veins. So essentially, you can think about it like if you have an occluded artery, you develop collaterals around that artery. And that's how that area gets perfused. Well, likewise, with the venous side, if you get some sort of venous occlusion, whether it's in a tiny parenchymal vein or whether it's in a cortical vein or a deep vein, you will get various patterns of rerouting and allow that area to drain properly. So there's this really interesting collection of images on the neuroangio.org website, and I encourage you all to go there and read about DVAs, or as they're called on that site, sometimes medullary venous malformations. But essentially, early on in embryonic development, we have these transmedullary veins. So basically, these veins that extend all the way from like the ventricular surface to the surface of the brain. And over time, these little veins, they kind of get disconnected from one another. So you do have some transmedullary veins, but then you have these interrupted veins that some are going to go superficial, some are going to go deep. And this is an example of that right here. But what can happen is if you lose like a superficial cortical vein, like on the surface of the brain, these veins here will kind of converge and then find a way to enter into the deep venous system. So that's what we think is going on with DVAs. And here's just another example of that. So essentially, like, here's an example, right? Example 3. There's no superficial cortical vein right here. So instead, all these veins that are in this gyrus are kind of going and converging into larger collectors and larger collectorals, and then into this big tributary. And various examples of that, here, loss of maybe a deep venous collector, so everything drains here and then into the superficial system. So what's the evidence for this? Well, actually, venous rerouting is something that we see all the time in angiography and in venography. So here's a patient that had a meningioma that was invading the superior sagittal sinus. And here's the initial angiogram right here, and we can see that there's interruption of that superior sagittal sinus. Well, the meningioma, grew and grew and grew and became much more extensive. And now on this repeat angiogram that was performed 7 years later, you can see multiple new venous connections. For example, this vein here and this vein here are now connected by this mature venous collateral that developed on the surface of the brain right here. Also, you can see here this mature connection with the superficial middle cerebral vein that developed as a result of the fact that these cortical veins here could no longer drain into that superior sagittal sinus. So we do see remodeling of the veins even into adulthood. So it's conceivable that this could happen in embryonic life and also in early childhood in the veins of the brain parenchyma itself. This is just another example of a patient who had multiple dural arteriovenous fistulas that were refluxing into the deep venous system, and you can see rerouting of the normal cerebral venous blood flow into the vein of Labbé right here. So all these veins here initially were going to the superior sagittal sinus or going to the deep venous system, but essentially all of them now are going into the vein of Labbé. So this brings us to our next question. Are DVAs congenital? So dogmatically speaking, people do think that DVAs are congenital. There have been a few reports of intrauterine DVA detection on ultrasound or MRI. Here's just an example of one such article where they saw this developmental venous anomaly on prenatal MRI. But our group actually published this article a few years ago where we looked at the prevalence of DVAs by age categories on post-contrast MRIs, and you do see that there's this steep upslope in early childhood, and then the curve kind of flattens thereafter. And this suggests that maybe there is some plasticity in the venous system in early childhood that could result in an increased propensity to develop DVAs, and maybe that plasticity goes away into late childhood and adulthood. Now, are DVAs benign? Usually these lesions are benign. So if I saw a patient that had a DVA that was detected, incidentally, not associated with any symptoms, I would not recommend any follow-up. I would, just say that they have a developmental venous anomaly because there's no preventative measures that you would put for this patient. However, a subset of these lesions can become symptomatic through a variety of mechanisms, and when they do become symptomatic, that's when we can discuss ways to palliate a patient, but none of them involve taking out a DVA or embolizing a DVA or anything like that. And I'll just show you some interesting examples. So the mechanisms by which a DVA can become symptomatic: you can have a mechanical insult, for example, neurovascular compression or hydrocephalus. You can have intrauterine ischemia, which can result in gray matter disorganization. You can have decreased outflow or thrombosis from the DVA, which can result in ischemia and gliosis, or even bleeding and formation of cavernomas. DVAs that are thrombosed can then recanalize, and sometimes this can cause arteriovenous malformation development. And then in some cases, you actually have increased inflow to a DVA. So for example, if a DVA is draining a brain AVM or is in the territory of a high flow dural arteriovenous fistula, and this can cause ischemia or hemorrhage. And I'll show you nice examples of each of these. So first, mechanical insult. So DVAs have been reported to cause trigeminal neuralgia. If you think about it, the posterior fossa is a pretty closed location. You can have a dilated venous varix from the DVA, and that can cause some mass effect on the trigeminal nerve. And it's actually the most common compressive neuropathy seen in DVA patients. There's been about 20 cases reported in the literature to date. And usually it's due to compression of the trigeminal nerve at the root entry zone. And these can be treated with microvascular decompression or ablation of the trigeminal nerve itself. So here's one example. You see this big DVA right here. This is the right trigeminal nerve. Here's the left trigeminal nerve. At the root entry zone, you can see that it's deforming the pons and compressing the trigeminal nerve. You can actually see the DVA right here on this angiogram and right here. And this patient went on to get microvascular decompression and did very well. And here you can actually see the venous varix from the DVA, and here you actually see the trigeminal nerve itself. Here's another patient. You can see the right trigeminal nerve here. This is where the left should be. It's getting displaced superiorly. Big venous varix from the DVA. Getting displaced inferiorly. You can see the DVA right here. And this patient just underwent balloon compression of the trigeminal nerve to treat the facial pain. There have been some reports of intrauterine, purported intrauterine ischemia causing gray matter disorganization secondary to a DVA. So there have been a number of reports showing DVAs coexisting with multiple types of cortical dysplasia or migration abnormalities, including schizencephaly, lysencephaly, heterotopic gray matter, focal cortical dysplasia, and polymicrogyria. It's important to point out that there's a close interplay between the cortical development and vascular development. So here's an example of a patient with like a polymicrogyria, and you can see here that there's this DVA running right through there. So it's conceivable that some type of thrombosis of the superficial cortical veins in this region precipitated the development of that polymicrogyria. So thrombosis of DVAs, this is probably the principal mechanism by which these lesions become symptomatic. So, the most common underlying cause of DVA causing symptoms is venous hypertension. And there have been a number of perfusion-based studies that have shown that there is increased cerebral blood volume and to some extent increased cerebral blood flow in the territory of the DVA. So there are some perfusion abnormalities in these areas. And oftentimes the symptoms related to these local regional changes from the DVAs are based off the acuity of the perfusion deficit. So if all of a sudden you have a sudden development of a stenosis or thrombosis of a DVA, you could expect that you would have an acute syndrome due to the fact that there's just not enough time for the brain to compensate accordingly. Whereas if things are happening a little bit slower, then perhaps various collateral pathways can form. So here's just example of a DVA that was associated with just increased cerebral blood volume in the territory of the DVA, and it makes sense, right? It's a slow flowing area, so you have dilated veins, so you are going to have an increase in the cerebral blood volume, and you can see that right here as well. Here's another example of a case with ASL, actually, where you can see the perfusion deficit right here relates to the presence of this large developmental venous anomaly. So what are the sequelae of this, chronic venous hypertension that can cause in the territory, that can, happen in the territory of the DVAs? Well, first you can get edema, you can get gliosis, you can get demyelination, you can get chronic siderosis, calcification. So here's an example of a patient who had slight right hemipresis, language abnormalities, and dysarthria. And you can see this large DVA in the basal ganglia and in the left hemispheric white matter. And here you see these chronic calcifications of the left basal ganglia, but here you're also seeing hypodensity in the internal capsule, hypodensity in the caudate, and the centrum semiovale. And this patient actually had a venous infarct due to a partial thrombosis of the developmental venous anomaly. So just a nice example of that. This is the T2 star MRI in this patient. So this is looking at iron, and you can see here that there's this mineralization of the left basal ganglia, and you can see that there's these striated veins in the left hemispheric white matter, which have a large amount of deoxyhemoglobin due to slow flow. Gliosis. This was a child that had seizures and oral automatisms and had generalized tonic-clonic seizure. They had an EEG, which localized a lesion to the left precentral gyrus. And you can see that there's this lesion right here. And then actually you can see that there's this little developmental venous anomaly corresponding to that lesion. So this patient probably had some gliosis or ischemic demyelination, which resulted in the lesion and then associated seizures. Regarding siderosis, so here's a patient that had right upper extremity chorea only, and you can see here that there's this mineralization of calcium and probably iron in the left lentiform nucleus. And you can see that there's this extensive DVA in that area, and probably what's happening is that the chronic venous ischemia and maybe microhemorrhage associated with that area could result in this mineralization of the lentiform nucleus and the patient's associated symptoms. DVAs can bleed. I know many of us have seen developmental venous anomalies which bleed. So the mechanism of hemorrhage is similar to that seen in dural venous sinus thrombosis. It actually may be a precursor to Cavernoma formation. So here's a patient that presented with a massive hemorrhage in the right hemisphere and right basal ganglia, and you can see the lesion on both the CT and MRI right here. And it looks like we have some different ages or compositions of hemorrhage within this lesion to begin with. Anyways, after a few months, the scar formed, the hemorrhage, was evacuated, and you can see here that there's this stellate appearance in the middle of the hemorrhage, which is basically the DVA that was underlying the lesion the whole time, and just a very impressive example of a DVA causing hemorrhage. You can see the radicals of the DVA right there. So DVAs are the precursor to Cavernoma formation in a vast majority of cases. It's a well-established link, and there's a theory of hemorrhagic angiogenic proliferation. And there have been a number of 7T MRI studies that have suggested that, in fact, all cavernomas are associated with local venous abnormalities, in particular developmental venous anomalies. So for a vast majority of patients, cavernous malformations or cavernomas are not congenital. They are lesions which develop during life and are usually the result of some local regional venous hypertension. So here's just a study that we did looking at DVA Associated cavernomas, and you can see here that the prevalence of DVA Associated cavernomas pretty much goes up with age. From about 1% of DVAs have a cavernoma associated with them from 0 to 10 years of age, compared to about 12% of lesions among patients that are greater than 70 years old. So what are the risk factors for cavernoma formation inside a DVA? So infratentorial DVA is one of the risk factors, and this may be to there's just more less space and maybe more kinking of the DVAs in these territories. Tortuosity of the DVA. So here's an example of a cavernoma in the left frontal lobe, and you can see that it forms in the radical of this branch of the DVA. You can see that particular branch does have a pretty tortuous appearance. DVA multiplicity, DVA kinking, because you can imagine kinking is going to result in some increased venous pressure in that area as well. And then lastly, any outflow obstruction and then inflammation. So one of the interesting things that can happen with the DVA is the development of an arteriovenous malformation within the DVA, and that can result in a vicious cycle, because essentially the DVA, you don't have any of that plasticity that you have in the normal venous system, and then if you place a DVA under high venous pressure, then you get all the sequelae of the venous hypertension, including venous ischemia and bleeding. So There have been a few case reports showing DVA-associated hemorrhages or cavernomas, which result in formation of an AVM at follow-up. And the hypothesis here is that you get thrombosis of the DVA, and then you get hemorrhage, then you get angiogenic response and inflammation, and then you develop arteriovenous shunting. So, here's just one case from Journal of Neurosurgery on de novo cerebral AVM formation in a patient with a developmental venous anomaly. And you can see here that there's this massive hemorrhage. And then you can see here that there's this huge venous radical kind of draining the area of this hemorrhage. And it looks like a cavernoma. And I guess the initial angiogram was negative, but then the patient got a follow-up angiogram which showed a massive arteriovenous malformation draining into the DVA and then to the vena galen. Here's a patient of ours that had this little hemorrhage right here, and you can see that there's this vein coming out. We didn't see anything on the initial angiogram except for a DVA in the territory of that bleed, and then on follow-up the patient developed this arteriovenous malformation. There's this concept of transitional venous anomalies. There's about 30 cases reported in the literature of these. Essentially, they're shunting DVAs where there's an arteriovenous connection, but they don't have the high flow characteristics of a normal brain AVM, like feeding arterial aneurysms or significant arterial dilatation. And essentially, the nidus is within the venous radicals of the DVA itself. So here's one such example. We see that there's this focal hemorrhage right here, and then there's this DVA which appears, but it's during the early arterial phase. We're seeing that there's these shunts that are happening in the periphery of the DVA, and then we see that there's this DVA right here, and then there's probably like a little stenosis of the DVA itself. So this is a nice example of a transitional venous anomaly. And then you can see in the normal cerebral venous phase how it's draining the normal brain as well. And you can see the DVA with its stagnant contrast column. And the patient got surgical resection of the AVM, and then the patient had a large venous infarct, and this is actually probably due to the fact that this AVM had bled, right? But there was already slow flow in this DVA that was draining normal brain, and then we resect the AVM, and you can possibly get thrombosis of the other radicals that we weren't seeing draining into the DVA, and that's probably what caused that venous infarct. Here's another case of a classic transitional venous anomaly where we see that there's this capillary blush in the early arterial phase in this territory, and then when we get in the kind of the capillary-ish phase, you start to see there's that blush, but then you start to see all these radicals of a DVA, and we get into the normal brain venous phase, classic DVA right here, draining into the left transverse sinus. You can see that here on the MRIs as well. Now, DVAs can also drain brain AVMs. There's about 20 cases reported in the literature. In these cases, you have a normal AVM with all the high flow characteristics, but the DVA just happens to be in the way. Now, was it involved in the AVM formation in the first place? Possibly, but it's hard to prove. But in these cases, the nidus is not within the DVA radicals. So in the transitional venous anomaly, it is within the venous radicals. In the DVA draining brain AVM, it's not within the venous radicals of the DVA. You actually get rapid opacification of the draining vein. So here's a patient with the left temporal arteriovenous malformation. We also see this DVA in the left temporal lobe. And then here we see the arteriovenous malformation, and then we see the DVA that's sharing the same draining vein as the AVM. So you can see right here, there's this draining vein right here, and then here that draining vein is also draining the brain AVM. So you can imagine that the territory that this DVA is draining is under a significantly higher venous pressure than it would be if it weren't for that AVM being there. The DVAs can also be associated with dural arteriovenous fistulas. There's about 6 cases reported in the literature. All of them, the DVA had some sort of complication associated with it, including hemorrhage, cavernous malformation, development, or venous infarct. And essentially what you have is venous hypertension in the draining dural sinus, and then that means that you're going to get venous hypertension in the draining DVA, then you can get infarction, bleeding, or cavernoma formation. So here's a patient that we had reported in Journal of Neurosurgery with this dural sinus malformation. And they actually had this DVA here in the pons. It was also draining some of the cerebellum and the vermis. And you can see here the whole extent of the DVA. And actually on the MRV, you can see the DVA is draining into that transverse sinus. So this transverse sinus is under really high pressure. Anyways, the patient presented with some headache and ataxia. And then you can see here they developed this new hemorrhage within the radicals of the DVA. And then on follow-up, you can see it has the classic appearance of a cavernoma. So essentially, the venous hypertension, in this DVA, they just happen to be draining where this dural sinus malformation was, resulted in formation of a cavernoma. Now, there are a number of syndromic associations with DVAs. So facial venous malformations are one of them, and something that I've been finding pretty interesting. There's cerebrofacial venous metameric syndrome, blue rubber nevus syndrome, Cowden syndrome, or Lermite-de-Clos. So first thing I'll talk about is the cerebrovenous metameric syndrome. So essentially during our embryonic development, we develop in these little segments called metameres, and the tissues, the endoderm, ectoderm, mesoderm, etc. And each metamere goes on to develop or contribute cells to all the structures in that segment. And many of the regions of our brain are actually linked to regions of our face. So for example, the hypothalamus is in the same metamere as the nose and the orbit. The cerebrum is especially the occipital lobes, in the same metamere as the retina, the optic nerve, the diencephalon, the maxilla, and the mandible is in the same metamere as the cerebellum and the pons. So what happens is if you have some sort of mutation in, for example, one of the venous progenitor cells in a given metamere, you can have all sorts of venous abnormalities in all the tissues of the metamere, whether it's in the brain, whether it's in the bone, whether it's in the muscle, whether it's in the skin. So here's a patient that had a venous malformation in the right temporal region and orbit. And you can see that venous malformation here, and then you can see this hyper-intense venous malformation in the right orbit. And then you can see it's extend into the soft tissues as well. And so this patient also had multiple developmental venous anomalies, including in the thalamus and the basal ganglia and the vermis and the left temporal lobe as well. So most of these DVAs developed in the same metamere as the orbits. That'd be consistent with like the CVMS type 2, or essentially cerebrovenofacial metameric syndrome involving the second metamere. Patient also had a dural sinus malformation, so markedly enlarged torcula and superior sagittal sinus, as well as a sinus pericranii. Other associations, there have been some articles showing association between DVAs and diffuse intrinsic pontine gliomas. You can see them in the setting of diffuse gliomas as well. Also in pediatric neoplasms. And there's also been studies showing higher odds of flare signals surrounding DVAs in patients with MS compared to those without multiple sclerosis. And then also there's this syndrome called constitutional mismatch repair deficiency syndrome, where there's basically 100% prevalence of DVAs, and this was actually reported recently in the American Journal of Neuroradiology. And the last thing I'll talk about is this concept of extra-axial developmental venous anomalies. So these include things like Sinus Pericranii and malformations of the dural venous sinuses, as well as persistent embryonic sinuses. So Sinus Pericranii, it's pretty rare. Basically, you have a large emissary intradiploic vein from the superior sagittal sinus that drains into the subgaleal space, and you often get a large varix. The most common presentation is a non-pulsatile midline soft tissue mass, which increases in size with Valsalva. And there's often a large communication between the intracranial and extracranial veins. And about 50% of these are associated with a DVA draining the sinus pericranii. So again, this gets to that whole idea of the metameres, how we develop in this segmental pattern, and the face dictates the brain, or the brain dictates the face. So sinus pericranii are characterized as dominant when the mainstream of contrast, when you do the venogram, uses the sinus pericranii to drain the brain and bypasses usual venous outlets. So these are difficult to treat. And then accessory, where only a small part of the venous outflow of the brain occurs through the extradiploic vessels. Here's just an example of a sinus pericranii that becomes more prominent with the Valsalva maneuver. So regarding management, so what we typically do is, if you have a soft tissue mass of the skull, you get a color Doppler ultrasound, you see a vascular lesion, you get an MRI or MR venogram, or CT venogram or CT. If a sinus pericranii is suspected, you can go on to digital subtraction angiography. Now, if it's a tiny sinus pericranii, often they don't need angiography and will undergo surgery without, any conventional angiographic imaging. But if it's a dominant sinus pericranii, in other words, it's draining a lot of the brain, then we preserve it, don't touch it. It's more of a cosmetic issue. But if it's accessory, if there's neurological symptoms associated with it, you can treat it. But if it's more psychological or dermatological concerns, then we kind of go with the patient's wishes, and then we consider treatments depending on the risks and benefits and alternatives. On cross-sectional imaging, you see on ultrasound the connection between the skin and the veins that are intracranial. On this T2 high-resolution MRI, you can see that connection between these cortical or dural venous veins and the subgaleal veins. You can see that again here on this MR venogram, that little connection, and then how it's draining into this extradiploic vein. And then there is another connection on a CT. You can do these surface renderings where you can see the actual hole of the sinus pericranii. And then here you can see the example of the sinus pericranii in this patient on the MR venogram. Here's just a plain radiograph showing a nice example of a big sinus pericranii. And this case was given me by Dr. Krings, who I think Dr. Lejeunesse had given it to him. And this is from the surgical neuro angiography book, showing a large DVA draining into this sinus pericranii right here. Regarding the association between DVAs and facial venous malformations, one article in the 90s found that about 20% of venous malformations patients had a DVA on angiography. In a study from the Toronto group, we found that about the prevalence of DVA was 30% among patients with venous malformations compared to just 10% in control patients. In about 80% of cases, the DVA was ipsilateral to the venous malformation, and about 75% was in the same metamere. So definitely a strong association there. And then in the Mayo group, we've found similar results, basically 40% case control relationship between DVAs and venous malformations. And then the last thing I'll talk about is non-shunting dural sinus malformations. So these are relatively rare, And essentially, what happens is during normal venous development, you have ballooning of the torcula and the transverse sinuses between the 4th and 7th month of intrauterine life. And there must be some unknown trigger which causes persistence of this ballooning. And it seems to be associated with Sinus Pericranii and DVAs and venous malformations. So something is wrong. Some sort of mutation must have happened with the cells that cause the veins in these territories early in life. And these are incidental, no-touch lesions. So here's just an example. Patient with lots of venous malformations, and then you see this, really large and kind of funny-looking torcula. So it's not a dural sinus malformation in the sense of the ones that we talk about where you have arteriovenous shunting, but it's definitely a malformed dural venous sinus. And this patient also had some other abnormalities, including multiple developmental venous anomalies and abnormal enlargement of the temporal horn of the left lateral ventricle. Here's another patient. This patient had incidental venous malformations bilaterally in the parotid spaces, but then they also have this persistent falcine sinus and this markedly enlarged torcula. And, these are completely incidental, but, nonetheless, they're fairly interesting, I think. And you can see here that the contrast just kind of swirling and pooling in this area on this conventional angiogram. Here's another patient, multiple venous malformations, extensive, and then you can see here developmental venous anomaly, and then this kind of ballooning appearance of the torcula. So it's definitely not normal, but it's of no, clinical significance probably. So in conclusion, the medullary venous system, it's much more dynamic than we think it is. There's a large range of clinical manifestations of developmental venous anomalies, and DVAs can be associated with a large range of venous and non-venous pathologies as well. Extra-axial developmental venous anomalies, including Sinus Pericranii and dural venous sinus malformations, are poorly understood. And I guess that's it. Thank you very much.